when before the pandemic, the demographic of race, ethnicity of our overdose, our poisoning death victims, similar to our Erie County demographics. So 79% of our Erie County population is categorized as white, and in 2018, 76% of our overdose death victims were white. Again, 14% of our Erie County population is categorized as Black, and in 2018, 13% of our overdose death victims were categorized as Black. Fast forward to, if you look on the overside on the right in 2024, you can see that these numbers has changed, and we're seeing a more diverse population of overdose death victims. So again, 14% of our Erie County population is categorized as Black. However, 33%, so twice more than almost 3 times that is the proportion of Black overdose death victims. So again, there's a disparity there. Again, 79% of our Erie County population, according to the census, is categorized as white, and 64% of our fatal overdose death victims are categorized as white. So again, the demographics are changing. Also, what's changed is over the years is the age. So before the pandemic, this was a big problem among the younger population, people in their late teens, 20s, and 30s, where people in their 20s and 30s make up about 25% of our population, but they made up about 50% of our overdose deaths in 2018. So again, and then people over 60 were just responsible for made up only about 10% of our overdose death victims. So fast forward to 2024. So again, this is changed substantially. So if you look at again, people over 60 account for 25% of our population, and now they account for about that same percent of our overdose death victims. And looking at Erie County, the proportion of people who are 40 and up in Erie County is about 50%, but the proportion of our overdose death victims is about 70% in Erie County of people 40 and up. So again, it seems that our fatal overdose death victims are increasing in age. They're middle age. They're more boomers, like me. So what else is we didn't show gender because the gender trends haven't really aged. I mean, it's still predominantly male. 70 to 80% of our overdose death victims are male. So this is looking at the drugs that are identified in the tox screen of our fatal overdose victims, and we're really looking at the most commonly seen or commonly identified drugs in the tox screen. These are all multi-drug tox screen results. I mean, there are multiple drugs identified, both opioids and non-opioids, benzodiazepines, cannabis, a lot of different drugs. But the most commonly what we see are of the opioids are fentanyl. We're seeing a lot of cocaine, and either fentanyl and cocaine together, or fentanyl and cocaine, separately. So cocaine without fentanyl, or fentanyl without cocaine. So, or then, just other drugs. So here we're looking at data of the tox screen results from, on the left-hand side, from 2020 to 2022, in the middle from 2023, and then the right-hand side we have confirmed so far in 2024. So you can see that there's a trend with an increasing proportion of our overdose death victims with fentanyl and cocaine found in the toxicology screen. And we're seeing even now more recent trends in the past year or two with just more cocaine in general. And so we're even seeing more cocaine without fentanyl in the toxicology results. And you can see now on the right-hand side that we're seeing, just as much fentanyl as, just as much cocaine as we're seeing in fentanyl in the toxicology screens. And, again, that the cocaine is, many times with fentanyl, but we're also seeing it without the fentanyl. So, cocaine is becoming a more important drug in our overdose death victims. So that's, really something that we have to look at. And again, the cocaine is more potent. People have always thought of it as a party drug. Many times it's spiked with fentanyl, or it's so potent, and whatever people are taking in addition, it's just their heart can't handle like all the stimulants and this vasoconstriction, and they end up going into cardiac arrest. So it's it's really sad. Unfortunately, another drug that we just unfortunately identified in our community in the unregulated drug supply is carfentanil. So just to remind folks, carfentanil is a very, very potent opioid. It's actually 100 times more potent than fentanyl. It's actually used in large veterinary medicines to sedate very large animals like elephants. So you can imagine like how potent it is. So we've seen this in 2024 detected in multiple sources, so not just from one source. Substance use treatment providers have found it in patients' tox screens. The Central Police Services toxicology lab have found it in drugs that have been confiscated as evidence. And then also we found it in toxicology screens in our medical examiner's office of our fatal overdose death victims. So, we're not seeing a huge amount right now, but it's in our drug supply, and we don't know if we're going to see more. So, this is something that also is very, very dangerous, and hopefully, our peers and you all can talk to your patients and get the word out about the danger of this. And our fentanyl test strips should be able to detect carfentanil. The problem is that since carfentanil is so potent, sometimes there can be such a small amount that there won't be enough for the test strips to identify. So, again, it's just because it's important to test with the test strips, but it's still important regardless of the results, just to advise our peers and people in the community, just to still advise people if you didn't buy the drug from a pharmacy, even press pill, just use a very, very small amount as a test dose just to see what happens, and never use alone. So this slide is looking at data from 2016 to so far confirmed in 2024 of all our opioid-related deaths that have both fentanyl and cocaine. So you can see that this has been steadily rising. It peaked a bit in 2023, but it's still pretty high. About 2/3 of our opioid overdose deaths have both fentanyl and cocaine in the toxicology screen. So again, this is a very deadly mix. So these are data looking at where overdose deaths are occurring, either in the city of Buffalo or outside the city of Buffalo. And so just to remind folks that the city of Buffalo right now has about almost 30% of our Erie County population. But looking at the right-hand side where people who died in Buffalo are in the blue bar, and people who died outside of Buffalo are in the orange bar. Ever since 2016, there's been a predominance of overdose death victims of about 2/3 who have died in the city of Buffalo. And remember, 30% of Erie County residents live in the city of Buffalo, but over 60% of our overdose deaths occur in the city of Buffalo. So on the left-hand side is a graph looking at the proportion of fatal overdoses that occurred in Buffalo among Buffalo City residents. So again, we have data that I'm going to be showing now that shows that actually, most fatal overdoses occur in people's homes, and about 2/3, and then an additional 10% were very near to their home. So at a friend's house, definitely within the same zip code. So, this has been a trend over the past couple of years. So, and then again, we're seeing a predominance of our overdose death victims who are Buffalo City residents. And again, this is a changing demographics. In the past, we saw a lot of first ring suburbs like, Cheektowaga, Lackawanna. We're still seeing overdoses everywhere in Erie County, but we're seeing a higher concentration in the city. And Jason put together a nice map that I'm going to show you just now. So as I mentioned, we're seeing a decrease in our fatal overdose deaths and our fatal overdoses in Erie County. This is actually a national and a state trend. So I haven't checked if this slide is still available on CDC's website. Much of surveillance data from CDC has been removed at the end of last week. But fortunately, Jason pulled this off before it was removed, if it was removed. So, so this is looking at the number of fatal drug overdoses in the past 12 months. That's what each dot counts for, is the number of fatal overdoses in the past 12 months. And so you can see that, you know, in 2023, the curve finally started to go down. And New York, there's been, you know, in the past year, a 24% decrease in the number of drug overdoses in the past year. The United States is seeing a similar trend where there's been a 22% decrease. So again, this is, you know, a good trend that we're, you know, we're hoping will persist. So now I'm going to talk about fatal overdoses in Erie County. And again, the data, the fatal overdose data was from our medical examiner's office. And so these are data that Jason put together that we received from law enforcement, from the high intensity drug trafficking area. And so you know, Jason at the Office of Harm Reduction put together these great slides that I'm going to show you. So this is looking at the number of non-fatal overdose reports that we've received from HIDA from starting in January 2023, going out until the end of 2024 by month. So you can see what is striking. Like overall, there's been an upward trend, which really peaked in the fall of 2024. We saw like a very large number of non-fatal overdoses. At the same time, we started to see we saw a drop in fatal overdoses. So we're you know, going to look at these data a little bit more, but we assume that the people were still overdosing and they were surviving because we, and hopefully because we've been very aggressive with harm reduction, and you know, there was Narcan on hand and somebody there to administer it. So we're you know, we're hoping that you know, that explains the number of decreased number of fatal overdoses, and so people can survive another day, and you know, which is our goal. So these are maps looking at where our overdoses are occurring. On the left-hand side are our non-fatal overdoses from the past 6 months of 2024. And then on the right-hand side, in the orange tones, are our fatal overdoses for the past 6 months. So you can see that looking at our non-fatal overdoses data that we receive from HIDA, you can see that there's, you know, many of the non-fatal overdoses are occurring in the city of Buffalo, but again, they're throughout the county. There's a lot of non-fatal overdoses on the west side. There's also a lot on the east side. There's a, you know, big concentration on the west side of Buffalo. Whereas looking on the right-hand side, there's a lot of fatal overdoses on the east side of Buffalo. So again, there's a disparity there. So, you know, really, this, you know, shows us that we really have to concentrate efforts working with our partners on the east side of Buffalo to, you know, target that population and make sure that, you know, people are, you know, living another day and surviving their overdoses. So these are the data that I have. Are there any questions? No? Okay, great. Well, if you think of anything, I'll be here for the rest. So now I'm going to invite up Dr. Jeff Block from Catholic Health, who is my partner in crime and co-chair and care provider work group.
Hi, I'm Jeff Block. I'm a hospitalist and internal medicine doctor that practices mostly at a sister's hospital. I'm also an administrator, and you know, really seeing, you know, people with substance use in the hospital, specifically in very acute settings, is kind of fostered by interest. Coupling with Gale and her experience. So
thank you. Okay. So I'm just going to start. So again, our goal of our healthcare provider work group is to, you know, make sure that we make some systems changes in the healthcare system, both in the hospital and in community physicians' offices, to identify people who are struggling with substance use disorder, and then make sure that they get into the appropriate care with harm reduction and treatment if they're ready for it. So I'm going to start off with some work that I'm doing with community physicians' offices. So, talking with community physicians' offices, I realized that most physicians in Erie County have no idea, what the New York State regulations are, where physicians are required to prescribe naloxone or Narcan for their patients. Just to remind you, for at least once a year, the beginning of the year, with a first prescription for any type of narcotic medication for patients that have a history of substance use disorder, or there's very high doses of narcotics, or if they're using other drugs besides opioids like benzodiazepines or sedative hypnotics that can really enhance the sedative effect and respiratory depression of the narcotics that they're taking. Physicians are legally required to prescribe Narcan, but they don't know it, so they're not doing it. So what we're trying to do is educate physicians about what the New York State law is, and then so hopefully that'll encourage them to prescribe more, and then also help them put a system in place that works in a very, very busy primary care office, so that they can identify those patients that need Narcan, and somehow, not necessarily the physician, but the healthcare team, somebody will train their patients about when to use it, how to use it, and then also educate them about the NCAP, the Narcan Community Assistance Program, which essentially will allow their patients to get their Narcan for free, and any co-payments will be picked up by the New York State Health Department. Another challenge with using NCAP is physicians' offices don't know about it, so patients don't know about it. And also many times, pharmacists may not know about it, or even if they know about it, they don't understand how to bill, because first you're supposed to bill the insurance, and then the co-payment is supposed to be billed for NCAP. But many times pharmacies are just trying to bill the whole thing to NCAP, and then it gets rejected. And so then the pharmacist will say, sorry, you got to pay for it. So again, educating patients so they can be educated consumers. So again, this is going to be a bigger feat than it sounds like. It would be such an easy thing, but it's not. Most primary care offices are crazy busy. Thinking back, if you've seen a primary care provider in the past couple of years, they're just crazy busy. And so we have to think about find an office that is willing to work with us, and then figuring out how we can do this so it's they'll want to do it, so it's just not a burden for them. We have to make it easy for them. So we identified a champion office in South Buffalo, and we're collaborating with the New York State Health Department to do this. What we think is they'll help us with the training materials. Our Office of Harm Reduction is working with some UB medical students, and we've putting together a presentation and an educational session. And so we're scheduled our first meeting to start planning. So hopefully we'll get out of the gate soon and be able to pilot something. Also, as I said, that many pharmacies are just not quite clear about how to use NCAP, or they may make it a little bit difficult or uncomfortable sometimes for patients to ask for a Narcan, a dose of Narcan, whether it be because they don't need a prescription, so whether it's prescribed or not. So we're working with Juvenile School of Pharmacy and the New York State Health Department to do a secret shoppers. So we're going to send pharmacy students into the pharmacies and see what their experiences are trying to purchase Narcan, with or without their insurance, and see if they are able to use the NCAP. So we're in the planning stages right now. Actually, the New York State Health Department and our Office of Harm Reduction, we independently had this plan to do this, like without talking to each other. And then we talked to each other like, oh, you're doing that too. So now we're going to, so hopefully it'll be a very project. So I'm going to turn it over to Jeff to talk about what some smart things that he's doing in the hospital. And I just also have to hand it to Jeff that we've, although Jeff's in Catholic Health, you know, we brought in the UB Collida people to, we have to really think of this as a community effort. So thanks.
Thank you. So, like I said, I work all in the hospital. So my focus, you know, over the past couple of years, we've really seen how substance use disorders and other psychosocial ramifications of people's life affect how people take care of themselves, their hospitalization. So, you know, it's an important facet to really look at is identifying people with opioid and substance use disorder. So really, you know, our aim is to improve screening and to identify patients with opioid agonist therapy and other substance use disorders, to start them on appropriate medications such as maintenance therapy, methadone, etc., or those patients who have substance use disorders with other substances that need psychosocial support. And again, it is identifying these people, providing support in the hospital, and really to plan for the next step, a safe discharge into the community, which is always a difficult task for the hospital staff. So we really wanted to also look at social determinants that are closely associated with against medical advice discharges in patients with opioid and substance use disorders. So really, we're doing this in two facets, actually many more. If you could, my next slide, I'll kind of expand on this a little bit more. But our system, Catholic Health System, has improved admission screenings for people who use substances. And I'm working with some pharmacy and internal medicine residents to look at social determinants of health in correlation with against medical device discharges in patients with opioid and substance use disorder. So, you know, probably a year and a half ago, you know, we noticed our nursing staff leadership has noticed that, you know, our nurse triage in the ER and the inpatient initial admission done by the RN bedside really was not very good. Really, all it had for substance use disorder was do you use street drugs, which is very, which is very open-ended, and you know, I think it makes people not want to answer, right? I mean,
which app do you want to open?
So, so you know, we've kind of expanded it. I'll show you in the next few slides what we did. However, I think this is just a starting point.
Sorry, I don't understand.
We actually started using the clinical opioid withdrawal scale as an order set in our electronic health record. Before we really we were bad at identifying patients who use substances, specifically opiates. Now we actually have, you know, we're identifying them and we're actually treating them with withdrawal symptoms with an order set that's similar to similar to like the CWA protocol for alcohol abuse, which most inpatient doctors know. Dr. Updike, who is really very active in this realm, is started a consult service only at Sisters, which really is the, you know, looking at the population of each Catholic system hospital. Sisters really, you know, where a lot of patients go proportionally to the other sites. And we also started, you know, myself, I've started complex care meetings, which is really about patients with complex discharges. So it may be linked to, you know, lack of family support or, you know, financial problems. But these patients with substance use disorders fall on these complex care meetings. We occur weekly with social work, pharmacy, physician leadership. We engage the insurance companies actually with difficult discharges, especially our local ones. May be privy to some of these meetings and cases. So this is the new hospital-based OUD identification. it really goes through a little more in-depth history about smoking, smokeless tobacco, cessation, drug use, sexual activity, and alcohol abuse must be missing. So this is the nurse's intake. So this history actually gets put into, like in our EHR, the main history. So when the physician goes in after, all these answers are pretty much, they're done already, and you can review with the patient. And this actually gets the physician thinking about, do I need to order cows? Do I need to order, alcohol withdrawal, SIWA scale? Do I need to, we do have social work, but do I need to get the social worker involved prior to the case manager opening the case? Because typically social work, you ask most internal medicine doctors who work in the hospital, social workers get you rehab beds, but because you're thinking about throughput, but their role in patients like this is much greater. And here, again, the cows order set, which is nice. You just click everything and it just populates to the electronic health chart. So originally, we were thinking, our original hypothesis for a research study was the lack of prescribing opiate maintenance therapies, such as Suboxone or methadone, impacts AMA discharges. But after we really looked at the data, that was not true. We actually prescribed to my, anecdotally, I was thinking we must not prescribe this to these patients, making them leave AMA. But we looked at the control group and the patients that left AMA. The frequency of prescribing or initiating, methadone or Suboxone was the same. So it kind of destroyed my hypothesis. So to go back to square one, but we did a data search. It was really interesting to see what some people were doing throughout the world. People were actually calling patients and doing kind of a questionnaire on why they left AMA, and some research groups looked at social determinants that impacted people leaving the hospital. So we really decided on, taking our hypothesis and just saying, like, let's look at social determinants, see which ones are more related to people who leave against medical advice, people with substance use. So right now we are in the process of looking at AMA discharge patients and non-AMA discharge patients from a 1 year standpoint, May 23 to May of 24. We're matching them by gender. We're looking at psychiatric history, depression, bipolar schizophrenia, anxiety, PTSD, smoking history, drinking history, housing and medical insurance, the type, Medicare, Medicaid, commercial, and could be our goal. This could be somewhat of a predictive model to kind of use for AMA discharges of people with substance use disorders. By looking at which social determinants impact AMA discharges, we may be able to come up with a screening tool so that could actually raise a red flag.
Could I add something? Only because I'm doing interviews with doctors around this.
Yep.
Readiness to change. That also leads into motivational interviewing, because I'm an anthropologist, but a lot of these things don't even get at whether somebody's ready to engage.
Yeah. And that's what you find even in the hospital. People come in, and a lot of bloodstream infections, and a lot of them don't want to change.
Or they're just sick of. Cheryl used to say when people say they're sick of being sick.
Yeah.
But anyway, the backseat driver.
Yeah. It's definitely we're trying to take something very complex and try to kind of really look at it in a systematic approach, which is hard, because it is so complex. But I do think some social determinants do play a role in why people leave against medical advice, so. Thank you.
Christine, would you like to introduce this shit? Hi everyone, we have a guest speaker from New York State, and so I'm just trying to find her so I can make her a presenter so she can present on these slides. Shay, are you able to unmute yourself? It did stop sharing the slide.
Do you want me to share the slides myself?
In 1 second, Shay, I don't think we can hear you. Can you try to talk again, Shay?
Yeah. Do you need me to present the slides?
No, it'll interfere with the.
Hmm.
I know, but she should be coming in through this.
Can you hear me now?
Shay, we might have to just have Dr. Burstein walk through some of these slides. Those interfere with the.
Can you hear me now?
And then, if we have any questions, if folks can jot them down in the chat.
Shay, I can hear you. I don't think you're coming over on our projection.
Yeah, we might just have to go with.
I just need to plug in my headphones so I can hear you guys.
All right, Shay, we're gonna have Dr. Burstein walk through some of these slides. If you have anything to add, if you can just drop that in the chat. And if anyone in person or virtually, if you have any questions, Shay will be available on chat and we can kind of talk back and forth. I apologize that this isn't working. Yeah, we just can't hear through the system. Here.
Okay, well, sorry, Shay, I'll try to do this justice. So I'm gonna talk about a new great buprenorphine assistance program. So this is something that if you're prescribing buprenorphine, you should be aware of. As a family planning provider, we have family planning benefits program that does this kind of the same thing with contraceptive methods. So this is a program that helps people who are uninsured, underinsured, or feel that they cannot use their insurance because of confidentiality reasons with explanation of benefits. It covers their buprenorphine, so they don't have to worry about. So insurance is not a barrier. So, for example, if say a young adult who is still on their parents' health plan, say they're like 21, 22, they have commercial insurance. They want to start buprenorphine, but they don't want the explanation of benefits to appear on to their parents to receive the explanation of benefits to see that their child, their son or daughter is receiving buprenorphine. So, and this would be an instance where the provider would be able to bill the buprenorphine assistance program, and so the patient would not have to pay anything out of pocket. They would not have to use their insurance and risk confidentiality. So also, if somebody's uninsured, this is a way that they could pay for it using the buprenorphine assistance program. So, and people who Medicaid does not send any explanation of benefits, and so so people who are on Medicaid, they can get their buprenorphine services covered, and there's no explanation of benefits. So people on Medicaid are not eligible for this because they don't need it. Does that make sense to everyone? Okay, so. There we go. Oh, thanks. So, I just basically talked about this. So, who is eligible for this program? So somebody has to be diagnosed with an opioid use disorder or at risk of an opioid use disorder. They have to live in New York State. They can be unstably housed. They don't have to have a permanent address, but they just have to be able to demonstrate that they live in New York State. So as I mentioned earlier, they, people who are Medicaid insured, or if they have, ADAP, that would also cover buprenorphine with no explanation of benefits. So they would not be eligible because they're, would need that with the type of insurance that they have. Also, person has to be 500% below the federal poverty level income. So, so if so what is uninsured? So the person has some level of insurance, but say it doesn't pay for the buprenorphine, or they have high deductibles or high co-payments, and so or if they have to use their parents or guardians insurance, and they don't want their parent for confidentiality reasons, they don't feel comfortable with their parents or guardians seeking an explanation of benefits. Also this could be true of a spouse, not just dependent, any type of dependent. So this gives them coverage. So to be a buprenorphine assistance program provider, you have to accept New York State Medicaid and either be a federally qualified health center, a hospital, substance use treatment center, a drug user health hub, or a harm reduction unit. So, so the process is the provider program staff are responsible for determining if they're eligible and enrollment. And the New York State side, they have to, make sure that, they process all the paperwork, make sure that they're eligible. And then after they determine eligibility, they will train the buprenorphine providers that enroll, make sure that they understand, how to use this and how to use the cards and how to enroll their patients. So this is a screenshot of the Bupe app application. So it's not very complicated. And Rebecca, have you started it already?
We have not. So you have to be a site that can provide and enroll people in the service. So we have training next week actually to
Great.
start doing this. Yes.
Great. All right. So so the other providers are doing this in our community. So if you enroll, you won't be the first one. And then you have to get from the patient consent for release of information. Then we have to get a point of contact between the agency and then the uninsured care programs. Email the UPAP folks at New York State. You have to, you see what's in the chat?
Yeah. If you do not meet the enrollment requirement, but feel like you would be a good fit as provider, you can reach out and we can discuss. And that's from Shay's presentation, this is. And
Right.
Emma said Evergreen Health is part of this initiative as well.
Great. So, again, I hope you can join on the bandwagon, even if these criteria you don't feel like you meet the criteria. It's always good to ask. If you don't ask, you won't get a yes. And so you submit the, identify a workflow, figure out like who's doing what with the billing and the case management and the outreach. You submit a provider enrollment form, attend the training, which is supposed to last about an hour, and then you can start identifying patients who can benefit from the program and register them. So if you have any questions, please contact Shay. Here's her email address, or there's a UPAP email address too if you have any questions. So does anybody have any questions? And hopefully Shay can respond to the app. Yes, in the back.
If they're unhoused, they still need ID to get their prescription.
So Shay, I don't know if you heard that. If they're unhoused, what kind of ID do they need for their prescription and to enroll in the program?
While we wait for Shay to respond, I think there was another question right here.
Do you know what that number is, the 500% below the federal poverty level? That's what you need to qualify, I think.
Right, it's a patient, yeah.
Shay, if you have, the dollar amount for 500% below federal poverty level, if you can put that in the chat too, please. And then we'll make sure that all these questions get answered, and I'll email all these answers out. And then Melissa, when Shay responds, if you can just, let us know.
She said, we do not require any form of documentation. They will be given a card that they can present to the pharmacy.
And then Emma said something about the type of pharmacies.
And then Evan said we should get CVS, Walgreens, et cetera, to stop mandating your state photo ID for view prescriptions. And Haley said about 68,000 for a single person household.
And as I mentioned, I'll summarize what's in the chat too and send it out with a summary so that we have all this.
And then for 2025, you said it's what, 78,000 for single family?
78,250 annually. A household of two is 105,750 annually. And then a household of three is 133,250. And then additional household members, you would add 27,500 for each.
Good questions. Anything else? Yes.
Does that cover the shot or just the strip?
So does it cover all forms of buprenorphine, including the injectable forms? They don't cover injectables at this time. Okay, thanks everyone.
Thanks,
Thanks, Shay.
Thank you, Shay. I apologize. Us folks in person weren't able to hear, so we'll try to get that worked out for them. All right, Val, I know we all talk about first responders. I know sometimes you want to come down, sometimes you're welcome yelling in the back. Ken is not going to be able to be with us today, but if he has anything to share out, he'll definitely reach out to us.
Good morning, everybody. I'm Val Zimnevich. I'm the Drug Intelligence Officer for New York, New Jersey, HIDA, covering Erie, Wyoming, and Chautauqua counties. What we're working on mostly right now is trying to tighten up law enforcement reporting so we can get the most accurate data that there is on current overdose trends to our harm reduction people, to the county health department, so that resources can be allocated properly. As in everything, there's a ebb and flow to it where things are going really well, and then after a little while they tail off a little bit. So we're trying to bring everybody back to where we need to be getting that data out. A couple things we can share is recently the DEA in Buffalo has made a seizure in one of their investigations of over 800 pounds of counterfeit pills and pharmaceuticals, ranging from everything from Opanas to Tramadol to Xanax. It was a long-term investigation they did, and they're continuing to follow it up. It's basically identifying people who are having precursors brought in and then finding where they're making the pill presses and making the pills before they go out on the street. So that should interrupt the drug supply a little bit in that regard. And as far as the carfentanil situation, we are looking at commonalities between the cases that have been identified with the medical examiner's office and the Central Police Services lab, to see if we can find any common links in those cases to try to figure out where a supply may be coming into the area with carfentanil. About 6 months ago, New York City started seeing a large increase in carfentanil cases. And Buffalo is a end user city, not a supply city. So generally a supply will come in from a larger city like New York. So we're trying to put some links together there. Those are the main focus we're working on right now. And again, trying to work as close as we can with the harm reduction groups to get the best data there is out there. That's really it for now.
Thanks, Val.
Sure.
as Val had mentioned, there has been some conversations about data and kind of the data flow and reporting and trying to find some of those gaps and links to really make sure that we're getting the best data and we're helping people collect the best data at the same time. So more to share. And later on in the task force, I'll kind of talk about some new initiatives possibly that the task force might be taking on. Juliana, and I don't see Jen here today, right? Okay, great. But Juliana will come down and talk about the treatment provider work group. Did you want the clicker? Or just a, right? Okay, you're not here too. On the computer.
Yes, okay. Hi, everybody. I'm Juliana Everdike. I work for the Department of Mental Health. This page is consistent from what we've presented before. My co-chair, Jen Side, and I from the South meet every fourth Monday with the group from 10:30 to 12. We are virtual still, but hopefully we'll be able to be in person in the next couple months. If you are wanting to be a part of the group, I know I've had a few people express interest. Please email myself or Jen. Our contact information is at the end of the presentation to be involved with our group. So I have a variety of things listed here. More so, these are topics of exploration that we've had in the past few months. We've talked about increased incorporation with prevention groups within Erie County. So I know that there's different work groups that focus on prevention, but we're also trying to pull that into treatment as well. Access to detox for stimulant use has been a conversation we've had for a while, as we've seen from Dr. Burstein and Jason's data points. The use of stimulants and how they're related to overdose is also increasing. So we're talking about what treatment facilities offer detox for stimulant use, what treatment options are available through OASIS. So those are still ongoing conversations. We've recently started to talk about the prevalence of alcohol use disorder treatment options just in general, because we know that polysubstance use and alcohol use being one of them is consistent with some of the increases in substance use that we're talking about here with opioids. The use of substances connection with increased chronic illnesses. So this is a new conversation that I'm going to be sending an email out shortly in conjunction with Taylor and her team, as well as some other community providers to talk about the relevance of substance use and how that is seen with chronic illness. Next task force meeting, we're going to have one of the health insurance teams. So Independent Health is going to be talking specifically about the reasons and stipulations that health insurance has around substance use treatment. So we'll talk about how they are involved with the discharge process through inpatient, and then also what differences are based from the health insurance and the treatment provider. So Liz will be here next meeting to talk about that. We're also starting to talk about overdose severity. So as many of you know, within the treatment field and DSM, there are different severities for substance use disorder, alcohol use disorder that range from mild to severe. But there's not anything that differentiates an overdose in that kind of layout too. So we're looking at some research. Unfortunately, there's a lack of research around this. And there's no set score right now. So we're looking at what that might look like from a treatment provider perspective, from a medical perspective, and how we can really assess the severity of that. So more to come on that, but it's been an interesting conversation that we've had in our group so far. And then also from some questions from the health department and Dr. Burstein, we're looking at HIV, hepatitis B and C screening. So which treatment providers supply these screenings, as well as vaccines for hepatitis A and B, and then also offer or referrals for HIV PrEP. So we're collecting that data and that'll be put into an Excel sheet so that everyone is aware of what treatment providers provide these screenings, treatment, and vaccines, as well as referrals. So one of the conversations we've had with Oasis is they are creating a different dashboard. So for those of you who are treatment providers, the Find Addiction Treatment website is now discontinued as of the beginning of January. That means that treatment providers won't need to provide a number of available beds that they have each day. So that was something they had to submit daily, which also means that the community and people doing outreach are not able to see the number of beds available in treatment facilities. So one of the questions I posed to Oasis is, are they open to any feedback from the community, from the task force, from our work groups of what we as people who are doing work on the ground see as a need to be included in that website that they're revamping. So if you have any feedback of what you would find helpful from a future platform on a state level, you can always email me, you can email the task force, and that can be forwarded, or you can obviously come to our meetings and talk about some of these issues. So Oasis did say though that the typical program search, so I did a little screenshot here. If you go to the Oasis website and put in a program search, you still can see the treatment providers that have availability, as well as calling the number that's here, but it's just it's another step, and it's a little more difficult than just doing the findaddictiontreatment.org. And these are a couple carryover from the last task force, but it's something that we want to constantly push. The forums that are available for grief and loss. We also have the East Buffalo Counseling Center with Spectrum Health. Western New York Independent Living provides grandparent support groups at these 2 different locations. And then these are the consistent information that we always put up for the South Opioid Addiction Treatment Hotline, as well as the Addiction Hotline through Crisis Services. And then just information about contact and the next meeting. And, oh, sorry, I do have one more thing. Just as of this weekend, the sheriffs put out a job posting for a MAT counselor within the correctional facility and the holding center. So that is posted on the sheriff's website if anyone is looking to apply for that. But it's a big step that we have working with correctional health, but also with the reintegration team. And correctional health, also their director, social worker, so she's kind of in that different setting. It's not like corrections, but it is that treatment and social work aspect.
I will try to find the posting and send that out. Yeah, that would be great. But I will send the posting out with all of our notes in the recording.
Okay.
Well, thanks.
Yeah.
Thank you. The clicker is right there. Perfect.
Good morning, everybody. I'm Jen Garrigan. I'm a project coordinator in the Office of Harm Reduction.
I'm Rebecca Lip. I'm Director of Clinical Services at Endeavor Health Services and co-chairing this project.
Yes, so I will resend our slides later because they got a little bit wonky in the download to make sure that everybody has the better versions of them, but we're going to go over our harm reduction work group. So primary goals and objectives when we started this last year, one of our big ones was getting a map back up on the website of ways that folks can access naloxone. With Jason's work and our data entry operators and our team, we were able to contact places that have our purple open stands that we've talked about in the past. So that is up and running. We are in the process now of kind of evaluating and seeing what else we can put up on there. Ideally, eventually it'll look like something where we can do a map with more treatment providers or different harm reduction resources listed on that. So we are in the beginning parts of that. Do you want to talk about?
Sure. So we are also going to be trying to engage people with living experience to get their feedback. and figure out where we're going with projects related to that. So I am going to be guiding a subgroup that we're starting related to doing some of that work. We are meeting for the first time actually tomorrow to have our first meeting, and are still looking for members and a champion to kind of lead that, someone who does have living experience. Yeah, working to bring it directly to communities through individuals who are already engaged. We're doing.
So, the other thing that we are doing is to try to, we have kicked off our radar subgroup, which is a drug monitoring and surveillance program through New York State, with a great partnership with Emma at Evergreen, as well as Yvette with Connections to Giving Back. Samples have started to be submitted to the lab. So we are kind of in our next step phase of seeing how that's going to function for us. So they have been sending things in, and we are going to be going through together with those entities what that data is going to look like. Because again, this is not, this is supply surveillance to help inform our people who use drugs in our community members. So this is not something that's going to say, okay, well, we had 5 cases of this and 5 cases of that. This is going to be something to help inform that public health lens, to provide educational support to our community members and to our partners with the help of New York State. So that is a very locked down process that we are sharing with them, that we will then bring back hopefully to our group to help make sure that our messaging is aligned with harm reduction values and principles.
Has the state worked out how they're gonna share the data?
We actually have a meeting with Radar with Matt and Lucilla this coming week, I believe. So they are going to, we do have a spreadsheet that we have access to for the qualitative data. The quantitative data has not been, we're not currently collecting those supplies because they're not sure how that part's going to be shared yet.
Yeah, it's just our slide about the people with living experience work group. So first meeting is tomorrow. If you're interested, me, my contact information is at the office. And we're continuing to openly recruit members. If you know anybody who should be interested, send them to me also. And then we're going to continue to discuss where we should be going, what we should be working on with feedback from our group.
Yeah. Yeah, and we're hoping to be able to build voices that can help to inform our practices at Erie County as well. And go through things like our consumer survey that we've had in the past, like make sure that those questions are appropriate, get proper feedback from folks. So we're really hoping to have a better collection of folks that can participate in this so that we can get that super valuable information. So next, we are working in the next 6 months. We'll be working to evaluate the radar samples and messaging, continue to meet with our groups. We'll continue to work on that mapping and see where we can get from that. And then the people with lived experience, hopefully that name will change, will come up with something.
A different name.
Something that's not quite so cumbersome. So our next steps really for this whole group are, what are the group ideas? What are the points of priority now that we've kind of started these smaller moving things? And how can we support our other groups within the task force? Our next full meeting is Wednesday, the 19th at 2 p.m. We meet the third Wednesday every month. So we'll be going forward with that. Does anybody have any other questions for us? And I'll just also really quickly piggyback with the whole data all together. As you know, I work on a first responder grant, and that's something that's been really, I've been very grateful to do. But collecting that data, not only from people with lived experience, but keeping our community partners engaged, keeping law enforcement engaged, keeping all of that to get that better data reporting so that we can have better follow-up with folks after overdose. So that's something that we're continuing to bring back to the group as well.
One thing that I do want to add that we forgot to mention is for the lived experience work group is we did try to apply for a small funding to be able to provide incentives for folks in this group who have lived experience. We unfortunately were not selected for that. So we are also trying to explore other innovative opportunities for incentives for folks who do have living experience so that we can compensate to some extent. Also hoping that we don't kind of only recruit folks who are in the professional world. Possibly there might be folks in the community who might want to be a part of this group as well. And so we want to make sure that we are compensating to some level to acknowledge the experience and the support and expertise. So more to come, but we were kind of hoping on that little small funding pot, but we'll get a little creative. Same with, and I don't want to overstep with you, Barb, and Barb will share a little bit more in the direction of her group, but I'm assuming we'll probably explore the same for your potential subgroup as well, since a lot of these folks are probably volunteers in members of the community. So I did want to add that before we got too far along. So thanks.
Shelby, did you have a question?
I just had, not to, right on your coattails, we have a community advisory board where folks are compensated $100 gift card for their time. We actually have our meeting tomorrow, so I think definitely want to collaborate and see how we can make these work together, because we do have like that funding source, and we actually are having a hard time recruiting folks. Last time we only had 2 people show up, so I think it would be a great opportunity how we can, use your people and our funding and make that work for both of us.
Yeah, that would be great. I think, yeah.
I'll put together a meeting for us.
Thanks, Shelby. Excellent. Barb.
Good morning, everybody. Barb is minus Ken today. He couldn't be here. He may be online. So Ken, if you're online, maybe give us a wave or something. So we are the Education Advocacy and Support Group. In early 2024, we became a new work group comprised of the prior family group and the Community Education and Awareness Committee. We really spent a good deal of time, which I shared with you at previous meetings, getting to know one another, what are the priorities of each group, and what should our new kind of combined priorities be. Who remembers when you were little and you might have had a pain or an ache and your mother told you it's growing pains and you were kind of like, what's a growing pain, right? We've been struggling a little bit. We've been having some growing pains. So we're just being real and being honest with you guys. But we are, I would think Kate would agree with me, we are a very hopeful committee. We are a not give up committee. We didn't just, we weren't just like, this isn't going well. It's, we just kept going and going and going and talking this through and brainstorming this. And after much discernment, deliberation, brainstorming, we came to the conclusion, oh my gosh, there's a typo. I can't stand typos, I'm sorry about that. Came to the conclusion that while we share a lot of common ground, there also is some different expected goals, outcomes. And we did reach this conclusion lightly. Very deliberative process as we went through this, because we wanted to continue to do the good work of each of the previous committees. We didn't want anything to get lost in the shuffle. So we began to discuss our options. We couldn't just keep plowing forward with kind of this like, something's just not completely in balance. So we discussed our options. Do we return to separate the previous model of separate committees? Someone came up with the idea, do we form, keep our committee, but then form 2 subcommittees underneath that? Or form 2 subcommittees of our merged committee, see how that goes, and then maybe determine if we need to return to the previous models. So what we came up with, we are going to stay one committee. One will focus on our previous goal of creating community awareness and continuing to educate the public. And then that second will focus on the family advocacy and the support. Each of those are important in and of themselves, and they need that individual attention. But then the two subcommittees are going to come together because, again, do share a lot of common ground. Jen and I are sitting next to each other the whole meeting going, we got to combine on this. We got to talk about this, So a lot of our committees do overlap. So we're going to then come together under the umbrella of the big committee and work on the bigger picture, such as events, promotion, the education, and the outreach. We continued to do, the good work that we did. We came up with our tear-off sheet. We had an amazing Black Balloon Day, which I'll tell you is already coming up for 2025. We had the wonderful event in August, the Overdose Awareness Day, which was really very, very successful. So we will continue to do the work that's been ongoing. But really, we're going to focus on our priorities for 2025 and how do we just make this all work? Because that's really why we're here. Again, we are a committee of doers, busy bees, and we're glass half full people. We're very hopeful, so we're not giving up on this. Sometimes it's easy to give up during a time of struggle. We're not going to do that. And I really think you learn a lot about people during a time of struggle. And not one person has left our table. So I think that's a big sign. As I mentioned, our first event of 2025 is going to be Black Balloon Day. So we're looking forward to that. We don't have a specific date yet, but when we do, we will make sure that we get that information out to you. So that's where we are. So.
And actually, Zach is going to be talking a little bit more about Black Balloon Day because there was a question about a possible date. We believe we're going to hold it at the same location as last year, but we wanted to open it up to everyone to see it. So we'll get to him in a couple of slides. This is new as of last task force meeting, this kind of specialty area. So right now, it is all of Erie County, but please, if anybody has anything that you would like to share and you have a presentation, flyer, or anything like that that you would like to share formally, please, this is an excellent opportunity. So just let us know. But I want to go over some of the feedback. So something new that we have started is to have an electronic sign-in, and part of that sign-in did have, I think, like, what do you expect to learn or find out, or what are your anticipations of today? And so we did get a lot of feedback. 83 at the last meeting signed in, and 25 provided feedback. There were some top 3 themes looking at the signees anticipated wanting to learn, or when they have provided feedback. And that was increased collaboration. It was data trends and possibly other research, and then respectful of time and purpose. And I actually just started keeping track of time, and we are like 4 minutes ahead of schedule, which is excellent, and I'm excited, only because I can get pretty lengthy in my conversations. So, but here's what do you hope to gain from this meeting, and this is what was signed in when people did sign in, what was asked. So more collaboration, data, increased collaboration, up-to-date information, latest updates, learn more about the data, get vital information, updates, and so this is just a sample of what a lot of folks wanted to learn. There was one down here that I wanted to point out, but someone had suggested that they want to learn about trends in the Black community. And so prior to November's meeting, we had a very brief conversation about, and I don't want to add more work groups, so I don't know what this is going to look like, but there was a conversation about having kind of like an ad hoc work group or conversation or group of people to look at specialty populations or specialty areas or topics. And so that might be a perfect opportunity to say, hey, we need a very specific message. We need very specific conversations around this one area, this one demographic, this one zip code, this one social determinant, so that we can really have a targeted approach and be able to seamlessly work across work groups, across organizations, so that we can have a more intentional approach. So that might be something, like I said, I don't know what that can look like in the future, but yes, we hear you, and that has kind of been on our radar, and so more to come about that. But most people did attend in person, but it does look like virtual is still a very viable and worthwhile option. How satisfied with the event? These were some feedback, how many task force meetings. So we wanted to gauge, are you a new person? Have you been here for several years? And then feedback came from many attendees from all professional levels and professions, peers, directors, community-based organizations. So that was really interesting to also see the variety of feedback from a variety of folks, but it all had those common three themes: collaboration, data, and respective time, because we know that 2 hours is a lot, even if it's only quarterly. On top of all of the time that the work group's fun also. What did you like about today's meeting? Again, that people like the data, people like talking with others, the flow, that it was relevant, which is excellent to hear back. And we do, again, something we don't know what it's going to look like, but we would love to incorporate more collaboration and collaborative opportunity as well, whether that's just a networking or whether that's through some guided activities to really create those conversations and those collaborations. How could the meetings be improved? Shortened. We always love shortened meetings, so we hear that. Continue with the structure, which is great. This individual had something really interesting, and I don't know if I have like a pointer, laser thing, but I know it's quarterly, but it's a long meeting, and it can be tough to give up 2 hours. Not sure what the solution is, because all the information is fantastic, but perhaps the updates from working groups could be sent out ahead of with the agenda, and then folks can come to this meeting with questions, comments, ideas to really kind of add on to those work group discussions. Really not something I ever considered, but I think it's an excellent opportunity and an idea and something that we could possibly explore. And these were just the ratings. I'm not going to go through all of it, but just I figured I'd include it. Also, so you all know that we're actually looking at this and hoping to make changes too. So we appreciate your feedback. So I'm going to jump into the settlement. Also plug, we do have the same feedback form, so please fill that out. I would love to hear from you. But just a few updates about opioid settlement. I left these in case folks look at the presentation online, but I'm not going to go through all of this because it is carryover from last meeting. But some new nuances. There has been an article that has come out about Purdue and specifically the Sackler family. We have not to date received any update on any amount that Erie County is expected to receive, but hopefully we will get some type of report soon on that. We also have started reporting to the Attorney General. So as I mentioned, that we get kind of 2 streams of opioid settlement funds. One comes through OASAS and then one comes through, it's our settlement, but that does filter down through the Attorney General. So we are figuring out the new reporting around that. Some new internal guardrails and processes. We are exploring and hoping to secure an accountant auditor. And that's really to kind of really make sure that our internal processes are where they should be and up to standard, and that we are holding ourselves accountable. And then we are looking into and hoping to kind of get off the ground with an external evaluation team as well. And so this will serve a couple of purposes. One, keep us accountable externally, but then also can also be considered really a long-term investment. We're hoping that a needs assessment will be completed, and that needs assessment not only will help inform settlement spending, but will also help inform all of your work so that you can explore additional funding opportunities as well. So that will be public for you too. Here's some updates on the Detect to Protect campaign. Through December 2024, we've been on radio, audio, and visual, and video, social media, and then audience-based displays and location-based displays. And impact, if you are online, please correct me, and I ask this every single meeting, but my understanding of audience-based display is that is really tailored to whatever the profile is of that particular person, right? So here are my interests, here's my age, here's all my other demographics. And location-based display is, even though I live down in Springville, that is not my targeted location. But if I'm in 14202, then these ads will pop up. So that is really based around the location of where that physical device is and where that ad is being sent to. And I just made that up of zip codes. I think we're targeting all of Erie County, but as an example, I think there are some heavier weighted zip codes, I believe. So November, we did have a tailored radio spot launched in response to an anticipated increase in overdoses due to the holiday season. So it did talk a little bit about holiday. December, we also had a radio message be aired during a Buffalo Bills playoff pregame show during the game, and then Monday through Friday on WGR, the radio station for the Bills. The campaign lift is 29.2%, which is significantly above the industry average, which is excellent. They go on to share what the lift means. Greatest activity to the website was Monday through Wednesday, 6 a.m. to 3 p.m. We have more than 9.4 million impressions on social media, 5.5 million impressions via the location and audience-based ads, 2 million impressions via streaming, 1.8 via streaming video, and then more than 130,000 visits to the website. We've had a 374% increase in ordering and distribution of fentanyl test strips. Some more increases in xylazine and Narcan kits. Overall, opioid overdose deaths did decrease, and this is, we did get some more final numbers as well, but monthly decrease from 40 in June to 25 in July, 23 in August. And so that is right after the campaign did launch. We also did have a significant response after we did the press campaign or the press conference about the Protect to Detect campaign. We had a significant response of folks visiting the website and ordering from the website from that press conference. And so when we move forward with press releases and conferences, we want to be intentional so that we kind of don't fatigue the community, but we use them strategically. And I think folks really like to hear from people who were in the campaign, which was an excellent opportunity. We did receive some awards for the campaign, so this is just some fun news. And now year two, we are going to be, but we are still kind of planning, but we are in the very last steps of finalizing the plans to begin acting. We reviewed opioid use and overdose data, conducted some focus group, our impact marketing team did. We did request testimonials from current campaign ambassadors to all of our models. We are beginning to plan a year two photo shoot in spring, so somewhere in Erie County. If anybody has some excellent ideas, we are open to them. So if you want to let me know, I will pass that along to our marketing team. And then we have curated lists of high-risk overdose spots, businesses, places of worship to help inform and refine. And here's my email. You are more than welcome to ask questions at the end or email me. All right, next we are going to try something different, which I'm a little scared about because I don't want to crash the video conference, but we did update and enter into a new phase 2 of our data dashboard. So Jason is going to try to walk us through live on the website. Now, folks online, are you able to see the erie.gov website? Melissa, are you able to see the erie.gov website? I'm sharing my, okay, excellent.
It does not come up on here.
Oh, shoot, sorry. It's not showing on here. I don't know what happened. Apologize, it's not showing on our screen in person. Oh, you know what? I can get out of presentation mode. There we go. Excellent, Jason. You are great to go.
Is this still showing on the WebEx? No, it's not stop showing on the WebEx.
Sure.
If you do share again, then do Microsoft Edge, it should be fine.
All right, now we're showing.
Yeah,
Okay.
good. Okay, great. Okay, everyone. For those of you who don't know me, my name is Jason Merlin. I'm the data analyst for the Office of Harm Reduction. And we'll be going over some of the changes that we've made to the dashboard. A lot of the information on our public dashboard has already been gone over by Dr. Burstein, so I'm mostly going to be focusing on the new things that we've added, the new features that we've changed since the last time we've displayed this. So the first thing that we did here is was added more historical data. So I think in the past it was only showing like 3 to 5 years, but now we went all the way back to 2014. So we have the full context of the past decade of overdose deaths. We still show the monthly view and the yearly view here, and we got rid of the weekly view because it was a little chaotic looking, and probably isn't really actionable to look at this data on a weekly level like that. We also added some additional customizability. We have this slider here at the bottom that you can move to limit the data view. So if you want to look at a particular range of dates or months to compare certain time periods, you can do that, and that will adjust. You can also enter a date in the little calendar widget here, and it'll adjust the date range accordingly. You can also select years from this drop-down menu, this selection menu over here, and so you can select specific years if you want to show. Let's say we just want to do 2022 through 2024. We can select those years, and it'll show those that data as long as that filter matches. All right. So that's the first slide where we look at overdose deaths over time. This is the updated slide where we discuss the substance distribution over time. So we've modified this substantially. In the past, this was just a series of pie charts like the one on the right, but showing the pie charts. I said that were essentially the same as the ones from the slides that Dr. Burstein shared. But here now we've included this line graph showing substances detected among deaths by year. So we have in red opioid-related deaths, in blue cocaine-related deaths, in this yellowish color benzodiazepine-related deaths, and in dark blue methamphetamine-related deaths. So these are inclusive categories. So this is so opioid, for example, opioid-related is deaths that involve opioids as well as any other substances. Cocaine is cocaine as well as any other substances. So some of these categories do overlap. So, as we can see in 2024, about 45% of our deaths involve both cocaine and fentanyl. And so there's significant overlap between these opioid-related and cocaine-related deaths here. So a couple things to note here is, as we know, deaths fortunately in Erie County declined significantly in 2024 compared to 2023. But the distribution of substances among our deaths has changed quite a bit. We are seeing fewer deaths that are related to both fentanyl and cocaine. Those detections have gone down from more than half of our deaths to, as I mentioned, about 45%. Also, while cocaine deaths have decreased, they are a bigger proportion of the overall pie than we have seen in the past. We now actually see slightly more deaths proportionally from from cocaine than we see from fentanyl. So cocaine is now about 62% of our deaths, and fentanyl is a hair underneath that. We also see that while we had a slight uptick in benzodiazepine-related deaths from 18 in 2023 to 31 in 2024, that is still near historic lows compared to where we saw in 2015, 2016. And methamphetamine-related deaths remain relatively low. So we're going to be adding additional customizability to this as well. That's kind of going to be a running theme where we want people to be able to customize the views and the data that they want to see. And we also want to be able to show this pie chart over here for other years as well. So we'll provide a drop down so you can say, look at the pie chart for 2023 or other previous years. This is our demographics slide, which we have moved its place in the order here, and we added some additional context and changed the layout. Previously we were only discussing the age distribution, but now we've added the race distribution of our overdose deaths. So we have the race distribution of 2024 overdose deaths, as well as the race distribution of Erie County, and it makes those disparities in population more apparent. Showing the differences in the size of the slices. A brief note on the other category here. Due to limited data of the other category in our medical examiner's data includes 8 people identified as Asian, Native Hawaiian, Pacific Islander, and multiracial. And so the slice designated other in the census distribution also includes those categories. So if you're wondering why some of those other categories aren't explicitly shown, it's because they were grouped together due to the limitations in the medical examiner's data. So as we see that, as Dr. Burstein mentioned, people who identified as Black are overrepresented in our overdose data by a significant margin. We also can see another thing that Dr. Burstein mentioned, that starting in 2023 and continuing into 2024, we saw a significant jump in the overdose deaths of people who are over the age of 50. So we are seeing a disproportionate impact on our older people. So we'll be continuing to update this in the coming weeks and months. We are open to suggestions for data that you would like to see on this public dashboard. This is right on our website at health/harm reduction data. And if you just Google Erie County harm reduction data, this will come right up. And I forgot to mention the mapping slide here, but this is as of yet unchanged from what it was before. This is still just showing overdoses reported by law enforcement and emergency service calls for the past 12 months. This is the data that we collect from HIDA, and we appreciate them very much for their work in collecting and providing us with this data. And this is essentially the same as what Dr. Burstein had showed. We also, so that's the summary of the updates for our dashboard here. We do also have approval from HIDA to discuss and hand out our heat maps that we make from overdose data that I showed. I think it was in the August 2 task force meetings ago. So if you're interested in that, we would love to talk with you. So I know some people have already expressed interest, but I would love to speak with you guys after and give out my card, my information, and we can have people request some data from us, and we can get that information out there. So that's all I've got. Thank you very much, everybody.
Thanks, Jason. As Jason had mentioned, this dashboard is ever evolving. We are in our second phase, but we really would love to hear from everyone in the community. If there is data that you think you would like, and it's not on the dashboard, and I should be sharing this, and it's not on the dashboard, but you want to see, do we have that data? Can we share that data? Please reach out to us so that we can actually provide data that you would find useful and helpful. So we would love to have that feedback. And I believe, Jordan, are you ready to come up? We wanted to have a quick conversation about expanding harm reduction from supplies into and expanding past supplies. So Jordan, I don't have any slides, but I have a holder place slide for you.
Okay. I'm gonna cup then.
Oh, maybe not. I lied. We'll just start right here. Sorry, Jordan.
All right, so I just wanted to speak, well, first of all, I'm Jordan. I'm the Training and Outreach Coordinator, Project Coordinator at the Office of Harm Reduction. So in general, in our office, we're really trying to make a shift towards just talking about amount of Narcan or amount of test strips that we hand out to folks to what does that actually mean in terms of health outcomes for people who use drugs, right? Harm reduction is so much more than test strips and Narcan. Those are just two strategies, right? Harm reduction is a philosophy and it's a movement of how we uplift voices of people with lived experience and living experience and how we support people who use drugs, right? And we all know this, but sometimes our data and our practice might not necessarily be aligning with that. One of the principles of harm reduction talks about really meeting the conditions of the person who is using, of their actual use. Where they are, what substances they're using, where they're physically forced to use, right? If they're experiencing homelessness or not. So how do we adjust the way that we, one, collect data and two, also support folks? So within the Office of Harm Reduction, we are really trying to shift towards more of those conversations, those community education conversations. When we hand out Narcan and we hand out test strips, instead of just handing them out, what substances are you using? Is this test strip applicable to what your substance you are using, right? For example, when we talk about xylazine, this is a substance we're normally seeing with fentanyl use. So if someone is actively not choosing to use fentanyl, then maybe a xylazine strip might not be the best for them. Who knows though, right? That's a conversation that we all have with folks individually, and it changes for each person. Another example of that is how we're talking about safer use supplies, right? So it goes beyond just sterile syringes and it's all the other works that goes with it. How are you storing your supplies? Are you holding on to your cotton afterwards? Are you storing it in a place that can't collect bacteria? These are just some very like cursory questions that folks could be having when you're engaging with someone who's using drugs. Or on top of that, recognizing that not everyone's injecting anymore. People are switching to smoking, right? So how can we support that use as well? Whether it be, smoking fentanyl or smoking methamphetamine, smoking crack cocaine. The smoking device is going to be different for each of those, right? So how are we talking through these different options with folks? How are we supporting the conditions of their actual use and aligning ourselves with the principles of harm reduction versus just handing things out indiscriminately? So I think that's just a shift we're trying to make, and hopefully we can encourage and work together with other outreach. Our peers are a big part of this change in the conversation that they're having with folks when they're on outreach. So if we're looking to collaborate with more outreach organizations, doing outreach together and kind of just building up our skills overall across the board, not just within this office.
And one thing, Jordan, thank you. And hopefully we will be exploring to bring in some more trainings and skill learning too for not only our team, but the task force and the larger community, which would be excellent. Thanks, Jordan. Yeah. Sorry to just, throw you.
I had it.
All right, Zach, can you come up and talk a little bit about Black Balloon Day?
That's not back to follow.
Thank you.
So my name is Zachary Kay. I am the family coordinator for Erie County Department of Health Office of Harm Reduction. We're going to talk a little bit about Black Balloon Day last year, what it looked like. And also I need your input as to what date we should host it at, because we want to have people join us so that we can support our community and support our loved ones and our family members who have lost loved ones to the opiate epidemic and overdose specifically. So last year we had it in the Portico Gallery at the History Museum, Buffalo History Museum. It was a very, very good, well-attended event. We had it on a Sunday. It was March 3rd. Historically, the date of Black Balloon Day is March 6th. That's when it is recognized. Because Taylor said I have 4 extra minutes, I'm going to get into the history of it. So with that being said, Black Balloon Day originated in Peabody, Massachusetts in 2016. We have observed it since that day. Or was it 2017 that it started? Okay. So essentially, upon its inception, we as a task force started utilizing that and promoting awareness. So with that being said, in 2016, it was started by Diane and Lauren Hurley, who lost their son and brother, Greg Tremblay, to a heroin overdose in 2015. The day is observed on March 6th and serves as a national day of remembrance for those who have lost lives to substance use and overdose. The tradition involves displaying black balloons outside of homes and businesses to honor the lives lost and to raise awareness about the opioid crisis. Since its inception, Black Balloon Day has grown into a national and international movement, helping to spark conversations about overdose prevention and harm. So with that being said, awareness is harm reduction. When we talk about what's going on, we need to be deliberate. And what I'm asking you good people is to come up with a date that would be suitable for you, whether it be March 6th, which is a Thursday, from 1 to 4 p.m., or whether it be Sunday, March 9th, which is a Sunday.
Sorry, I'm going to interject, Zach. I do, on the feedback form, I do have those dates listed. So if that's the only question you want to answer, you are more than welcome to just answer that question.
And this is what, these are some slides of what it looked like last year and who we had in attendance. Our individuals who spoke were family members that have lost loved ones to overdose. We had our Deputy County Executive, Lisa Shamara, speak, along with our Commissioner of Health, Gale Burstein. We also had special guests from the Erie County District Attorney's Office, Michael Kane, and then also from the U.S. Attorney's Office, we had Trini Ross, and we had Michael Adler speak. Very important to note, this is a very somber day, but it also gives us an opportunity to pay tribute to our loved ones and the lives that they led. So as you can see here, this is what it looks like. We have been given the opportunity to utilize the newly remodeled auditorium at the Historical Museum. So we will have space for about 180 individuals. There we have some members of our Office of Architecture. One thing that's important to note, and this is a very special day for me. My father, who was a musician for the Buffalo Philharmonic Orchestra, that was the last time that he was able to, was that last year. So with that being said, if you guys can get that feedback back to us, we can book the date. It will be at One Museum Court, whether it be on the Thursday, March 6th, or whether it be Sunday, March 9th. Thank you.
If it's Thursday, is it evening an option?
It would be from 1 until 4 or 2 to 5. The museum is open until. And they're giving us an opportunity to utilize the museum at no cost.
Thanks, Zach.
Does anybody have any questions?
Thank you. And I do, as I mentioned, those questions about the dates are going to be on the feedback form, as well as if you wanted to be involved. So if those are the only 2 questions you want to answer, that's absolutely not an issue. Jordan, here you were. And so lastly, I would love to hear from the community, folks who are in the audience in person. You are welcome to shout out. Folks, unfortunately, if you are joining us virtually, if you can add into the chat, but if there's anything going on in your world that you would love to share with the task force, that would be excellent. And Melissa, if anybody does talk in the chat, please let me know.
Okay. I do have one question if nobody.
Yeah, no, jump.
Someone asked, would you be able to comment on the doses of naloxone being used in the community and how they are working in fentanyl overdoses? And then they just said, I'd imagine the doses need to be higher and given more often, but just told me to verify.
Yeah, so I'm going to paraphrase a little bit, but the question was if we could comment on the dosing practices of naloxone in the community, as well as specifically related to carfentanil, which is a lot more potent, potentially assuming that we would need to increase the dosing to be able to reverse that individual. I've got probably a couple more experts that can speak on this a little bit better, but there is something in one of the newer trends or conversations in the naloxone dosing practice world is compassionate naloxone dosing, and that isn't just for carfentanil, but for really any other substance that an individual may have consumed or had taken. And so really the idea about naloxone is just to get that person breathing. And sometimes we think that breathing is standing upright, having a conversation, but it's not conversations, it's respirations. And so Jordan, Jen, I know both of you have worked hard on this with our new TOT, if you wanted to expand on that.
Yeah, basically just the information is that you want to make sure that people are breathing stably. So we've really shifted our focus in our naloxone training and are expanding our trainers to discuss that you give naloxone until the person is breathing. You're not going to have somebody jump up right away. You're not going to have somebody responding. That used to be the message. With some of the contaminants that we're seeing, that's no longer the case. Somebody that consumes xylazine or medetomidine or some other adulterant, naloxone's not going to do anything, but continuing to give them naloxone can actually cause more harm than good. You can put somebody into precipitated withdrawal. You can have somebody have a much more severe reaction. So just kind of finding that balance. We shifted away during COVID a lot from providing rescue breathing, but we're back to recommending rescue breathing if you're prepared and if you're comfortable. That's kind of the messaging. So you can kind of use that yourself. There are breathing shields available. There's a lot of different resources available to help be able to provide that resource to somebody in a safer way.
Yeah, excellent question. There also has been in the background, well, actually even public forums, there has been the conversation around increased dosing. We typically use the 4 milligram, but there has been conversation around providing like an 8 milligram. A lot of harm reduction advocates and harm reductionists in this space and medical professionals have shied away from recommending the 8 milligram really for that reason. And if we go back a couple of years ago with another grant, we had looked at a lot of first responder data, and the average dose in Erie County, or the average number of dosing for Narcan in Erie County was 2. So really, as long as somebody, and I would imagine that might still be true, we should probably look at that data again. As long as somebody has 1 dose at least and has alerted emergency personnel, they should be on their way, and hopefully we can have another dose being provided. Yeah. Anything else, Melissa, online? Excellent question.
Oh, sorry, I just wanted to also comment. I mean, places where overdose prevention sites like in New York City or Vancouver, now they're even trying to maybe avoid giving Narcan and try to stimulate breathing just by giving oxygen. So, oxygen can do a lot more than I think that we had imagined that it had, or breathing. And also, unfortunately, we don't have a good data here about Narcan use with carfentanil, because fortunately we haven't seen a lot of carfentanil, and perhaps when the radar program starts getting going, we might have more experience with identifying carfentanil in our substances and seeing or with the the crime lab, they may if they identify more carfentanil, we may have more experience. But fortunately, with our fatal overdoses, there've only been a handful of positive carfentanil tox screens so far.
Thanks, Gail.
But again, I don't know what the denominator is, like how much carfentanil there is out there.
Any questions from the folks in the audience? Anything you want to share?
Oh, I have a question just about the stimulants. I guess detox plan, or is that more? Is it just like detox? Are you trying to do maintenance, or that's all kind of little experimental right now?
Right, so that came from outreach workers, community health workers, saying that people were identifying that they only use stimulants were being disqualified from rehab, inpatient, detox centers. So we had looked at which locations of different sites were taking people who were stimulant only. If you want to jump in too, but Oasis does not have any type of approved treatment for stimulant use. So we're trying to find ways around that in order to get people that need the care that they need.
Yeah, I mean, it's just so frustrating because the science hasn't really caught up with the morbidity.
Yep.
Excellent. Well, thanks everyone for coming. Thanks everyone for joining virtually. We do have a feedback. Again, I would love to hear from any of you of your concerns, challenges, solutions, wins. Please send us that feedback, and we will definitely be considering some of the solutions that are provided, and hopefully we will see some other forms or ideas in the future. So thank you.
Oh.